Somewhere else, maybe? Always know the differences between your precautions. What kind of things get put in airborne precautions? What kind of conditions? TB, what else? So the still is. I know. Chickenpox. Chickenpox goes in airborne precautions. Yes, really. Because if you and I are sharing the same airspace, you cannot touch me, you cannot go within 6 to 9 feet of me, and I still get chickenpox from you. So chickenpox is airborne precaution. As a fun fact, I know. My daughter, when she was little, she went to the movie theater, and she broke out with chickenpox the next day. It's probably like everybody else out of the theater. Droplet is what kind of circumstance? If they cough on you, right? Droplet. Context pretty self-explanatory. And sometimes when you get to these kinds of questions during your NCLEX or an ATI question, sometimes as nurses we just want to put it all on, right? Like, just put it all on because it's just going to protect everybody from everything. That's not what NCLEX or we or ATI want to know. Do you know how it gets transmitted? Therefore, do you know what to wear to protect yourself? And be cost effective and be smart about it. So they don't want you saying, I'm going to put everything on for every condition. The long and the short of it. And as a caregiver, if you're aware of what goes into what kind of precautions, it's easy to implement those. Err on the side of putting in precautions until you get those results back. You can always take them back out of precautions versus wishing you had and you're backtracking. All these people have been exposed to that patient. If you hear that word cohorting, that means putting patients together that have similar circumstances. So as we talked about the patient with neutropenia, you would never group that patient with another patient, period. So that word cohorting means if you have to make a decision and you are you're the nurse manager today and you're trying to figure out patients you have to put in combined rooms, you get exposed to the construction today. And now you're combined rooms, think through, do they have anything that might be infectious that you will not put them in a room with someone else? So I give you the patients that are going through chemotherapy treatments or undergoing cancer treatments, and I give you a white count of 2, an A and C count of 500, don't cohort that patient with somebody else at all. So could you make decisions on that given that information? As you know, there's lots of nurses and things out there. Don't need to cover anything more with that. I know why this is part of the chapter that was. I'm not going to spend any more time on it. We're going to cover it next week. Anybody have oncology questions? Do you feel like you're pretty clear on what kind of things are most important to know about your patient?
I guess that was the end of the oncology. I put it on my other one because I was like, for over a week. I'm mostly lost about 75% of the time as to where the patterns.
I think on here we have, there was, I think she has, I don't remember the SIADH.
Oh,
But she didn't say we needed to do it. Well, I guess maybe
we
we
already
should.
do that.
Yeah, we didn't, yeah.
Hematology we're covering entirely separate from what we just went over, so we'll tackle that in a bit.
So we're going
So the test next week will be half renal, last week, a 4th oncology from this morning, and a 4th hematology, which is coming up. That's how the test questions get divided next week.
So oncology.
How many questions next week?
100. Oh,
Renal
50.
is for Sheila.
So there'll be dosage calculation questions, which means there's about 45 content questions, which means there's about 22 from last week, about 11 from this morning, and about 11 from hematology this afternoon, is how it kind of gets divided out. And your final gets divided by 11 weeks equally. You have 11 weeks of class, you have 5 weeks of test. So your final gets divided by, you'll have 8 or so dosage count questions on your final, which means you have about 7 or 8 questions per week. would be you have 24 mental health questions, because that was 3 weeks of time, right? I know I saw the drums coming back in the row, but that's the way it goes.
How many doses?
I thought she said 8 or 9.
Okay, we're gonna switch to hematology. I'm gonna figure out where my
I'm actually like all of a sudden really hungry. I want to go get my food.
How much are you getting? How much do you event do you get?
Did anybody not
So
take a
I'm
handout
only on the
last week?
second up from I started, and then we got the one bump.
If you did not take one last week, here they are. I didn't run more off after last week. I assume that you took one last week, you're gonna bring it today.
Because I started
If
with
you weren't here last week, I've got 2
Point 10
handouts for the
and-
next,
Okay.
wait, yeah, 0.10 is what I
I thought
So then
they
you
were
would go
called
to point 20?
And then I went up to 15. And then I went up to, I want to go up to 20.
Wait, what is she?
That's the paperwork from last
We
week.
already got.
Yeah.
Okay. Which one is this study? I failed the quiz so badly. I had 3 quizzes. I got like less than 2. Like 1.2.
And then I
You
looked,
got 2 quizzes. I had 1 point.
I looked at the book. You know what I put the first one? I put the child care in there, but only for 15 minutes or something.
Oh, I didn't
No
even
children
put that.
should even be in there.
My computer leaked out partway through the test, and I got back in, but I wondered if all those, even though I got back in, I just didn't put those in or something.
Oh, the good thing is only like what, 4
It's only worth it, but still, it makes me
Yeah, I need it.
because I hate those. They're just like, we haven't studied and we haven't learned about it. I don't even know where I'm supposed to find all this stuff about.
book.
I had the book open in front of me looking through it at the same time, and it's
It's
like,
impossible. That's why I would suggest having the book and having it on the side
I did.
to search the keywords. Because like
Oh,
you can search.
yeah, because
You could have searched for like T1 or N1 and it would have given you the graph. But I had that up and I was like, it was just like foreign to me, like Chinese when I was looking at that part. Because the way it's worded is like different.
it is.
And it was like a big graph with a lot of T1s, T2s, T20s, N's and V's.
I watched Nurse Sarah, I think it's the one, on staging, cancer staging. Made the most sense. Like, I didn't even look that up in the book. I think I probably got that one right out of all of them. Because anything I can find that she puts in there, she makes sense to me.
disorders first. And the header should be on your handout.
What are we going over?
And then for prototype combined, we'll do that very Okay. These fall into the non-malignant hematology neoplasms. So these are not blood cancers. These are hematological conditions. Anemias, as you know, the definition of decreased red blood cells. As you can tell from your handout and your reading, there's lots and lots of different types of anemias. The theme is the same. The theme is the patient's going to have decreased red blood cells, and it doesn't really matter from a nursing standpoint whether it's an issue of not getting enough produced or the issue of them getting produced by the patient's story. It makes no difference at all. So you don't have to differentiate between them because you're worried about caring for your patient, what caused the anemia, and management of that. So the issue is the low red blood cells equates to low hemoglobin. That's the amount of oxygen your red blood cells are not with you, and that's going to be causing the problems for your patients. The issues that go with you having low hemoglobin, there's lots of symptoms that go with that. They're pretty straightforward. iron
Oh,
levels
wait, never mind.
for your patient that cause her anemia. In the United States, the most common cause of iron deficiency anemia is blood loss. Because our diets are pretty good with having enough iron in them. So your patient presents with a low hemoglobin level, a low red blood cell count level. You're going to try to pinpoint what's caused her to have this anemia. Of course, do lab work and evaluate what her iron level is. Because most often you're going to start to try to pinpoint where the blood loss might have come from. Lots of things, as you can tell, a lot of them are GI related, things that cause you to have low iron levels. Again, low hemoglobin and hematocrit. Decreased size of the red blood cells is what that MCB means. Only way we can really diagnose it is to aspirate bone marrow. On your notes, an unusual finding with iron deficiency anemia is these weird cravings that they may have. As you go through, I would differentiate, maybe is there something unusual about this one that maybe is different than the next one. On your cover sheet are the symptoms we just went over. For all the anemia, your cover sheet will be all those symptoms that go with anemia, no matter what the cause is or what is going on. But iron deficiency's got these weird cravings. Also with this one is some of the neurological things that you can see. Restless leg syndrome, the smooth and red tongue. I would star those on your notes. That's a little bit unusual for this type. Different a little bit from some of the others. And of course, the treatment's going to be to try to replace her iron. Promoting iron-rich foods. Some of them are on here. Next, anemia is due to renal disease. As you know, the kidneys produce what hormone? Erythropoietin. We talked about that last week. Because of the kidney disease, you don't have enough erythropoietin get produced, and therefore you have not enough red blood cells that get produced, therefore low hemoglobin. We covered all that last week. You could be anemic because you have an inflammation. You could be anemic because you have damage to the bone marrow itself. Which is responsible for producing all those red blood cells. So therefore, all the cells that your bone marrow produce are going to be depleted. That just makes sense. You just told me they have anemia because their bone marrow isn't working right. All the cells the bone marrow is responsible for are going to be depleted. Oftentimes this one is sometimes we find damage to the bone marrow due to an ingestion of a high amount of benzene products. So I would make that little star in your note. This is what is a little bit unusual about that. Benzene products are an airplane glue, paint removers. So your patient, find out where your patient works, what his hobbies are. Is there some connect there? So that is a risk factor. Because the whole bone marrow is messed up and can't produce the cells correctly, we may have conversation about stem cell transplantation, which we already went over when we went over rheumatic diseases. Maybe it's due to too little folate. And all these deficiencies, as you can see, I tried to put a little one-liner in here. What does that do with red blood cells? Anyways, you don't have to know that that's what folate does, but sometimes I'm looking like, I don't know what that has to do with red blood cells, which is why I love folate levels. Bless you. The sizes of red blood cells go with this one. This one I would probably differentiate, kind of mark your symptoms with this one. As you can tell, they're more neurovascular symptoms that the patient experiences with this one. Because that's what caused it, promoting increased folic acid in your diet. As far as hematology goes, I probably won't really ask you food. grapefruit, some of those. The foods will come into play, yep, definitely from last week's content. The potassium foods, beans, all those things. No, it's high in folic acid. I know, you all do, I know. As soon as I see grapefruit on there, I'm picking it. Don't let that get you, because that may not be bad. Anemia due to low B12 levels. All these vitamins, all these things play an important role in keeping your red blood cells where they need to be. But B12 especially, when you have a low B12 level, it's usually related to something with GI, as you can see. Because your B12 gets absorbed in your GI tract. Normally, unless you had one of these conditions, you don't have trouble with low B12, just by the way things are designed. But following any of those kinds of surgeries, you may experience low B12. Absence of intrinsic factor is you were never born with a factor that absorbs your B12. The other cause is you had something that occurred as a patient that caused you to have low absorption. The bottom bullet is you never had the factor to begin with to absorb your B12. When that is the case, that's called pernicious anemia. Pernicious anemia is you were not born with a factor, intrinsic factor, that allows you to absorb B12. That's called pernicious anemia. You will be on a lifetime of B12 vitamins, so you can't absorb it if you don't have the factor that's needed. And we'll put you on lifetime B12 so we don't have you develop anemia over your lifetime. Low B12 levels, your body compensates for a long time. Again, the smooth red tongue, the neuro issues, oral supplements of B12. Questions about that one?
What's the difference again between the pernicious and regular anemia?
A regular deficiency was caused by some acute event.
Okay.
You had GI surgery, you got Crohn's, some reason that you have the intrinsic factor, you've been absorbing it, but you've had some condition or event that has caused you to not absorb it the way you need to. Pernicious anemia is you never absorbed it to begin with.
Oh, okay. Okay.
Because you weren't born with that factor.
Okay, thank you.
So, a couple slides back, you had said, Hallmark lab vitamins decrease MCV.
Yes, and you don't have to know the sizes of, MCV is the sizes of the red blood cells.
So
Sometimes they're big, sometimes they're little, you don't have to know that as a student. Is that what I was supposed to say?
Yeah.
Because it doesn't matter, I mean, it matters, but it doesn't really, right? You're still treating anemia, you're still gonna figure out what caused it here, and I don't really care if you know whether they're big or little. I'll tell you if I use them. Because you need to know that. There should be other things in your brain you gotta keep track of besides that. Okay, so all of those anemias I just went over, so there was not enough red blood cells that got produced for whatever reason, for all those reasons. Now, we're talking about anemias that fall into a different category, is the red blood cells that produce they get destroyed too early. Sickle cell disease, we'll talk about sickle cell crisis, which is important. Sickle cell disease is that those cells are formed shaped like sickles. Like sickles that they used to use on the farms, like to hack at the, whatever they're doing.
I call them these.
Instead of round marbles, like yours are shaped, theirs are shaped like sickles, and they get stuck. They don't flow through really nicely. It's an inherited disease. Again, pick different parents if you don't want sickle cell disease.
Just put them up for adoption.
At risk of persons of African descent is a risk factor for sickle cell disease. You didn't cause sickle cell disease as a patient. It's inherited. Your cells are supposed to be round and marble and flow through nicely, but your cells with sickle cell disease are shaped like sickles, they get stuck in the bloodstream, just by the way they're shaped. Oftentimes we can diagnose it in childhood. They start to have issues early on. Life expectancy is not sometimes great. We've come a long ways with that, but because they're just inherently shaped that way, we can't really fix that as far as fixing the way they're shaped. That's what causes you to have anemia, that's the way they're shaped. Diagnosing is looking at your red blood cells and noting that. You start to evidence symptoms of hypoxia. Your blood's not flowing through real nicely like it would be if they were rolling around. Lots of things that go with hypoxia. Crisis is when they get stuck and they block traffic and they impede blood flow. Causing you to have intense pain, the same pain you have when you have chest pain with a heart attack. Or same pain when you have pain when you've got to put blood flow anywhere else. Same thing. Because they got bunched up and they've gotten stuck and they've impeded your blood flow. This is important to know. These are some things that would trigger you, could trigger you. You being the patient that has sickle cell disease, for you to go into a crisis. These are researched and found triggers for that. Important for you as a nurse to know. You can identify by their history, maybe what brought this crisis on, and for you to educate your patient about these things. You have sickle cell disease, that was diagnosed quite a long time ago when you were a child. Let's try to learn about, monitor, prevent things that are going to trigger you to go into crisis mode. Crisis meaning that your cells get bunched up and they impede your blood flow. Your big jets, they're pressurized, but your little small airplanes are not. So small aircraft that aren't pressurized can cause a sickle cell crisis. High altitudes can cause sickle cell crisis. So you go hiking in Denver, you go places, climb mountains, that can cause that. Infections, dehydration, changes, big swings in climate. So we tell these patients, you know what, we want you to keep your room at the same temperature all the time. Because we don't want the big fluctuation in your temperature, or we don't want you going out when it's 20 below, or going to the beach when it's 100 degrees out. Because that may trigger you to go into crisis mode. Emotions, procedures, surgery, phase. Vaso-occlusive, as it says, it's included the vessel completely. The sickle cells have gotten bunched up, causing hypoxia. Normal, typical symptoms that you would picture, imagine, anytime we block your circulation. Treatment is to manage the symptoms. Your priority is keeping breathing, circulating. Aplastic is another type of crisis. This one is what we call the crisis that occurs when they bunch up within the spleen. We have lots of treatments that we can do. There's some great things that are happening to prevent the cells from getting bunched up. This is key for you as a nurse. Key for you as a nurse is either A, to prioritize that patient, keep him breathing and circulating when he hits your door. B, to prevent him from having triggers, or to identify triggers. I'm going to give you some patient education about things that you can do to prevent yourself from going into crisis mode. No high altitudes, no severe swings in temperature. Try to manage your flu. Get a shot, because the flu may set off you to have a crisis. High altitudes, non-pressurized flights. Those are things like helicopters, small airplanes, not the big jets, they're pressurized. Pardon me? I don't know. Probably some thoughts on that. The question is about today, avoid live vaccines. Because it's not really infection, I don't know. It might be. No further next week, but it's a good talk. But you flying on your airplane, their patients to keep them out of crisis mode. Or given a patient chart, when it comes to a sickle cell crisis, could you figure out maybe what triggered it? Lots of body systems involved, as you know, with impeded circulation. We can do stem cell transplantation. We can give meds that are hopefully improve the circulation. We got multi-organ failure. We can talk about transfusing. Some of these I'm going to buzz through pretty quickly because we could be here all day talking about all these different anemias. The theme, the cover sheet will be something that we started off with when we talked about those. Again, decrease in hemoglobins. Lots of diagnostics to figure that out. This deficiency makes the membrane unstable. There's different causes of anemia that are related to X-linked defects. Some of those are interesting to kind of track back. Maybe. Triggers, this could be for any of anemia. Triggers for red blood cell breakdown. NSAIDs, they're called red, and copper street drugs are found to have been a cause for you to have red blood cell deficiencies. This is when the antibodies destroy themselves, as the word says, immune hemolytic anemia. Hemolytic means breaking down because of a self-attack. And sometimes those bunched up cells like to sit themselves into your spleen. So we'll find that when we get to some of the chronic leukemias also. This is probably the biggest, most important part of this type of anemia, because the system self-attacks and they're anemic, and you're going to get him some red blood cells. What could happen with those red blood cells that you're going to get in them? The body can also self-attack. So we have a situation where the body self-attacks their own red blood cells. You're going to try to promote red blood cells by giving him red blood cells, and the body has a high risk for also attacking the ones that you're going to give to him through his IV bag. So your job as a nurse, knowing that could be the potential risk, is to start it very slowly and keep a really, really close eye on your patient. Knowing that he's at risk for breaking down those cells that you're giving him in his IV bag, because that's what his anemia is. So this is the biggest caution that you as a nurse need to be really promoting safety and monitoring that. Yes, actually.
I mean, how do you know while you're transfusing that they're attacking?
What could be going on with that? They could be developing your typical symptoms of a blood reaction. Low blood pressure.
Will it be within like the first 15 minutes or? No?
Yes, it could be, but also knowing that that's the state he's in, it could be high, for him, it could be high risk throughout his transfusion.
Thank you.
Typical patients that don't have this, you're exactly right. The hemolytic reaction typically occurs in the first 15 minutes. But for him, in theory, we could have this occur anytime.
It's gonna present as like a reaction to the blood pressure.
Is that right?
Okay, we need to stop transfusion.
Yes. Well, can be for increasing blood levels.
She said low blood pressure, but I'm like, also, I'm pretty sure like they can get a risk.
Probably one of those medications that we would want to discuss. Yeah, hard line to follow, but, good questions. Again, what caused it is a question, and if it's a bunch up in the spleen, of course, then we have to remove the spleen, promote pneumonia vaccine, influenza vaccines, those that are not virus vaccines. And immunosuppressants, as we talked about already, because if it's a self-attack, it's an overdrive of the autoimmune system, so that's. Here's where there's too much iron, it gets absorbed from the GI tract and it goes part itself other places. Iron builds up in the organs, causes all kind of organ issues. In this case, because there's too much iron built up. You may have to have a patient come in for therapeutic phlebotomies, where we remove iron from your bloodstream because you have this hereditary condition. 1 unit of blood removed decreases your iron by 200 to 250 milligrams. So it's effective, and we just got to keep managing your overload of iron. Some of the students have seen them do that with patients in the cancer center. Oh, really? Well, timely. How often was that patient getting done? And he comes back how often? Every 6 weeks? So Jordan said they had a patient yesterday, he comes in for these every 6 weeks for about 15 years.
So is it like, kind of like how like dialysis is, where they're like cleaning it or taking it out?
Taking it out. Yep.
They don't replenish the body?
So do you get
Blood
blood
too
at the
thick.
same time, or you just,
What?
you just lose what you got now?
The
Like,
body
do they
makes
replenish it,
money.
or they just leave it?
They don't replenish it, but you replenish it yourself and then you're overloaded. And you're back again 6 weeks later.
They like generate blood.
I would say probably not, but
Yeah.
because it's all automated stuff going on. And then as you know, if we're checking hematocrit and trying to figure out how often we have to do them in each patient. Well, but every 6 weeks for 15 years, that'd be a long time. I mean, I don't do them. And I had different, I think it's a set of parents. We don't want to do anything that's going to increase your iron absorption. Okay, polycythemia. Poly means many. In this case, there's too many cells of all types. Which way will your hematocrit go? Up. Which way will your red blood cells go?
Up,
Platelets,
up,
white cells,
up.
all of those. So the problem with this condition is there's too much going on. This little first tube shows your proportion and ratios that you're supposed to have normally. The third tube is what's going on with this patient, evidencing increased hematocrit. So there's an imbalance of red blood cells. In this condition, this patient has too many red blood cells, as the word says, and this is what he's experiencing. Instead of that first nice ratio, he's having too many red blood cells. The bone marrow overproduces. So primary means that your bone marrow is just not functioning correctly, nothing that the patient did, but that's just how it was created. Secondary polycythemia is there's some kind of activity, disease, condition that caused him to have an overproduction of red blood cells. So anemias were not enough red blood cells. The condition we talked about before was there's too much iron. This condition is too many red blood cells. That's the problem. Making for thick, viscous blood, poor blood flow because it's too thick, it's like ketchup thick, because there's too many cells floating around in that
Oh my
bloodstream.
gosh, that's really catch up thick, she said.
Red, congested, thick, not flowing nicely because it's too thick. Again, we may have to pull off some blood until we get your hematocrit where we want it. We want your hematocrit to be like that first test tube or that first tube on that first slide. Questions about polycythemia? Too thick, too many cells of all kinds. Neutropenia, different condition, different day. Neutropenia is decreased number of white blood cells, as the word says. Lots of things can cause you to have a low white count. A and C, we talked about that earlier. That's the phagocytosis. That's the neutrophils that can do a good job of phagocytosis, chewing up the debris, getting rid of it. Lower the number, worse things are. I feel like it's been turning down. Oh my gosh, what is going on? One consideration is if you've got a patient's got neutropenia and you're trying to rule out what it might or might not be, if he's taking corticosteroids, he may not present with an infection. If he's an older adult, he also may not present with a fever. I should say with a fever. So just because mom doesn't have a fever doesn't mean that she may not have an infection. Okay, this one is a low platelet count, as the word says. So polycythemia was too much of everything, all the counts were up. Break the word down and figure out what's too much or too little. In this case, low platelet counts, therefore causing low hemoglobin, low hematocrits. Symptoms that go with low platelets. Bleeding, bleeding, bleeding. Other indications of bleeding. Treat or not to treat depends on what the number is, how it's affecting the patient, so forth. You may have to get in platelets if the number gets too low. Okay, this case is too little platelets, but it's some kind of stimulus that causes platelets to get destroyed. We don't know. Because you have too little platelets, you're going to have symptoms that go along with bleeding. Not that unusual or unexpected. Try to get you to a safe platelet count so you're not going to bleed to death. Maybe you need to boost your immune system. The problem here is with an immune deficient response. IVs to give you some immune boost. Stay away from the herbs, the meds, the things that cause you to have decreased platelet function, which some of you all missed that on the last question. Probably ibuprofen, right? That's an NSAID, that increases your risk of bleeding. That question I was probably the one that was most missed. Hard to put on that. The G herbs. Sometimes the problem is just a defect of the platelets, because the count might be normal, but the function is not. Things that could cause you to have increased bleeding, as we just talked about a second ago. Stay away from that which caused it. I love that commercial's like, do not take this med if you're with this med. Okay, hemophilia. There are two types. A is a lack of factor VIII. That kind of rhymes, that's kind of that. There's with that one. A is 8 and B is 9. Both of those factors are needed to stop bleeding. Both are X-linked traits. Most of the time, the affected people are males. Females can carry it, but they aren't usually symptomatic. The problem is, it's usually a bleeding in the joint. They don't have a needed factor, whether it's 8 or 9, that causes you to clot when your knee gets injured. It does not allow them to clot when their knee gets injured or their joint gets injured, and that's where the problem is. Can occur in all body parts, typically in the joints. They bump their knee when they're outside. They come in, their knees this big around, and they've got bleeding. They can see a hematoma develop immediately, unlike if you just mildly bump your knee. In the caution, of course, the most concerning area of bleeding would be in the head. So you walked out of here and you bumped your head on the doorway. That's their biggest concern for them, because they may have bleeding that goes on immediately, unlike you who have normal platelet counts. Yes?
So, can it be A and B, or is it always A or B?
There's not always the case, it's usually A or B.
You're right.
But we're human beings, so they may have A and B combo, but usually it's A or B.
Okay, thank you.
Good question. So indications of bleeding, as we just covered. Factor replacement therapy, especially if they know they're gonna undergo something traumatic. I'm scheduled for tooth surgery coming up, I'm scheduled for some other kind of surgery that I'm aware of is coming up, some other surgery. So they can load them up with the factor that they're missing before they even head into surgery. Maybe you get you loaded up with that factor so you don't have any concerns while you're in surgery or post-operatively. There's medications that can increase your factor that you're missing. Patient teaching. Be proactive. Load up with your factor before you're going to go into something invasive that you know is going to be potentially a risk for bleeding. Stay away from the herbs, meds, things that are going to cause you to have increased bleeding. You can avoid injections. Make people aware that you have hemophilia. And sometimes then they just keep factor at home. They're missing factor at home. They wake up tomorrow morning and they've got bleeding in their knee because they were out last night and they did something that maybe traumatized that. We had somebody at our wedding party that has hemophilia, and he danced at our wedding, sent a picture the next day of his knee, and it's like, he goes, worth it, I'm loading up with factor 8 today. Like, okay. Questions about that one? This one is deficient protein.
I thought you said Miss Wilbur.
Like you can see, there's a zillion things that cause you to have bleeding issues or related issues.
Oh my.
Same thing, increased bleeding. You replace the factor that's missing. Maybe due to your liver dysfunction. Almost all your clotting factors are made in your liver. Liver problems equates to sometimes clotting problems. Maybe the coagulation disorder is related to you having a lack of vitamin K. Sometimes long-term use of antibiotics causes it to go potassium level. The potassium teaching now with vitamin K deficiency, the vitamin K concerns to try to keep your vitamin K intake of green greens and that greens at a constant level. Don't do this up and down thing with your foods that change your vitamin K levels. DIC, we just talked about that. Clotting and bleeding all at the same time. We talked about the lab a bit ago. Indications of bleeding. Again, the treatment, we just discussed that. Trying to stay ahead of that bleeding. David coagulation is related to too much homocysteine. Increased risk of clot, so that just makes sense, increased coagulation. Maybe there's a decrease in antithrombin levels. Anytime you have too much clotting going on, obviously for PEs, DVTs, strokes, all those kinds of things. So I would say for these disorders, when you're trying to sort them out, which way is it going? Is it too much bleeding? Concerns that go with that. Is it too much clotting? What complications or symptoms or issues go with that? Kind of in your head, keep that clear as to, well, what's going on with this one, what's going on with that one. Without worrying necessarily about some of these, you can be here all day talking about the cause you have all of those. Okay, so for anticoagulation therapy, that may be a prescription for that patient for whatever reason. When you're on warfarin, you do have to go in for regular lab work testing. If you get sent home on warfarin, if you get sent home on one of these other ones that are listed here, they are anticoagulants. You don't have to have blood work done to monitor your INR, your TT levels, stuff like that. So sometimes I'll get like, how do they pick who gets what?
Band.
Well, you
Band
have,
training.
the patient has a
Train
broken
band.
leg, they've been immobile for
Singer, band and train.
3 months.
And
I'll probably send you home on
Train
something other than warfarin. One of these other ones just keep you from getting a blood clot while you're laying there in bed. My sister that had the PE, she had a major event. She will be on warfarin the rest of her whole entire life. Little event, maybe we'll put you on anticoagulant for a period of time. Big event, we may have you on that forever. So you're educating your patient, and he says, well, I got a prescription for Eliquis. Do I have to come in for any kind of lab work? No, probably actually once a year, like your routine lab work. Or he says differently, I got sent home on Coumadin. Well, yes, you're gonna have your lab work checked. So advantages are, if you keep an eye on your lab work, we can usually dial in your right dose for Coumadin, right? Otherwise, you send home on other ones, and we're like, well, we're hoping that your clotting and your coagulation and all that stuff's exactly where we want it. Teaching your patients about anticoagulant foods. Again, these will make your blood thinner. Be consistent on your intake. These are also vitamin K rich foods. Vitamin greens are there.
they're in the PowerPoint, Lisa.
This coagulation disorder is related to protein C. I just want to know who sat and figured all these proteins out. Who knows what? I mean, I want that. What did you say? I know. I don't either. Protein S levels, again, too much clotting, too many platelets are gonna cause all these same problems with too thick of blood, too much, an increased risk of stroke, blood clots, embolus, thrombosis, all that stuff. Anticoagulant therapy, we talked about that. Complications, of course. You know, you take your Coumadin, you send your blood too thin, and you got issues with bleeding. Again, protein resistance. A constant state of thromboses, clotting, blood clots, especially in critical veins, vessels. Anticoagulant therapy again. Heparin. You guys already studied heparin. We talked about strokes, right? I'm not gonna go over that again. Too little platelets because of too much heparin. Monitor your patient for signs of bleeding, signs of clotting, clogging up. Aspirin sometimes, you know, the thought used to be, let's just put everybody on daily baby aspirin if we think you're at anti-cardiac risk, if you're a certain age. And not very long ago, I went into the cardiologist with my father, and the cardiologist goes, you know, we're kind of like not doing that anymore. He said, what medications do you take? And my dad said, oh, baby aspirin every day. And he goes, we just aren't really doing that unless we have a perceived need. We sort of think that's not necessary anymore. So stay tuned. Okay, questions about those? Yes. So really, what is the only one that we actually have to check your flower? And that will be prescribed if we need to be both your ion or anticoagulant levels. Unlike if we put you on that. Yeah, that's good to patient teaching. Sickle cell crisis absolutely will be on there, that's crisis, that's emergency. And then just go through your notes and kind of what are some hallmark symptoms that go through the big ones we talked about, if it's something unusual. Your patient comes in with this, what symptom do you expect to find? Your cover sheet for the ones that are too much clotting, your cover sheet for the ones that are anemia should be the same for all of them, right? Let me think, low red blood cells equates to low hemoglobin. How does the person feel, act, how will they present if they don't have enough hemoglobin on board? Much different than a patient that's got too many platelets. What kind of things go with people that have too much clotting and too big of blood? That's how your brain needs to separate those out. Break the word down. Polycythemia, too many cells. Anemia, neutropenia, thrombocytopenia, too little of those things. So it should be easy to figure out. Break the word down and say, okay, is it too much, too little? Knowing that, what issues will they have? Probably my best